Hi, everyone. Welcome to this unit on dopamine blocking drugs for the most part. We're going to be talking about things that historically have been called antipsychotics, but this is one of those places where the name can be quite confusing because these are medications that we use in other conditions besides psychosis, such as bipolar disorder and the augmentation of depression. So we'll be breaking this up into several modules going forward here. The first one, just a little bit of review about receptor activity and also a little history on on antipsychotics because I think it's kind of interesting. So what I'm hoping to help you understand is how we use these in different the data that exists for using these in different disease states, and also to understand how the receptor activity affects the way that the drug creates not only a benefit, but also side effects. And we'll be talking about both first generation or classical antipsychotics and second generation, or known as sometimes atypical antipsychotics. Sometimes the first generation are sometimes referred to as typical antipsychotics. So we have to remember that for a long time, we didn't have anything to treat psychotic illnesses. We really had just kind of incarceration care where people would be held in asylums probably for much of their lives if they developed a disease like schizophrenia. So really, when the first treatments were being developed, they were really quite crude by today's standards. So they were things like hot and cold baths, and then it was noted that when patients who also had epilepsy would have a seizure, that often after their postictal state had cleared, their mood would often be better. So it was thought, let's see if we can figure out a way to induce a seizure. And one of the ways that that was first done was with insulin. You could cause somebody to have a seizure and a coma with insulin, obviously very dangerous. And then electricity comes along as a means of doing this in what is known as electroconvulsive therapy. Its early iterations were very crude and quite kind of barbaric. The sort of the classic icon of this is Jack Nicholson in One Flew Over the Cuckoo's Nest, about to get bilateral ECT here. This has been refined to a much more to a much less harmful process, but there are still risks to things such as memory, but usually is done unilaterally on just one side of the head. But really, the first antipsychotic medications didn't come along until the early 1950s, when the drug chlorpromazine, also known as Thorazine, was being used as a surgical anesthetic. And somebody had the idea of trying this out in people with schizophrenia and found that it had these kind of quieting effects. And, this is often said to have been the beginning of the deinstitutionalization movement, when people could be treated with medications outside of asylums and possibly live in the community, which has been, arguably kind of a mixed success. So these medications spawn a number of different iterations. These are known as the first generation antipsychotics, or FGAs, and they were quite effective for the sort of positive symptoms of schizophrenia. Now, if you remember the distinction between positive and negative symptoms, it's not a value judgment. It's not these symptoms are good and these symptoms are bad. Positive symptoms are things that are added to the person in a way, so such as hallucinations or delusions, whereas negative symptoms are things that are sort of subtracted from the person, such as volition, so avolition, alogia, not really having thoughts or having disorganization of thoughts. Um, uh, Social withdrawal is another common symptom of schizophrenia. And the medications that came from chlorpromazine, the first generation antipsychotics, were not very effective for treating that. They really could reduce things like auditory hallucinations and delusions, but didn't really help with some of the social withdrawal and some of the functional impairment that we see with schizophrenia. And the downside is that prolonged exposure to them tends to cause something called tardive dyskinesia. They can have acute movement disorders that are associated with the use of these drugs, but long-term treatment can cause something called tardive dyskinesia, which can be very stigmatizing. These are sort of abnormal movements that we'll talk about a little more later. And then in 1989, the first second generation antipsychotic or atypical antipsychotic comes along in the form of clozaril. So the second generation antipsychotics, as we'll talk about more, block both dopamine and serotonin 2A receptors, which actually allows for dopamine to be released in some areas of the brain where we want it, while trying to block dopamine in areas of the brain that we don't. These were generally considered to be better for negative side effects, or sorry, negative symptoms of schizophrenia. It's arguable how much better they are, but that was the promise. And the problem with these was that they did not generally cause as many of the movement disorders, but they caused more metabolic issues. So these tended to cause people to gain weight, to increase their cholesterol, and to increase their blood sugar. So the problems that came along with that, and many of the subsequent medications that came during that era, such as olanzapine, quetiapine, and some of the newer medications that have been around in the last 10 years or so tend to be more metabolically neutral, which is a positive thing. So just a reminder that we're talking largely about dopamine, and for the most part, we're talking about blocking postsynaptic dopamine receptors. Although when we have a little bit of a glimpse into what's coming down the road, we'll be talking about how we might be able to prevent dopamine release rather than just blocking the postsynaptic receptors. So the areas of the brain that are affected by this, we're mostly looking with psychosis, we're looking at things like the ventral tegmental area, the nucleus accumbens, these what are known as mesolimbic pathways. We'll talk more about that in a moment. But dopamine, in addition to having this modulating effect on psychosis when it's in excess, when there's excessive dopamine activity, dopamine also has a role in movement and lactation, which is where we see some of these side effects that we're familiar with from antipsychotic medications. Dopamine, as you recall, is synthesized from L-tyrosine, becomes dopa, then dopamine, and then goes on to break down to become norepinephrine and epinephrine. There are these four pathways, which we'll talk about in more detail as we get into this, but the ones that are most relevant, the one that is most relevant to psychosis, at least the positive symptoms, are these mesolimbic striatal pathways. So the ventral tegmental area, the nucleus accumbens, you're probably familiar with those from work in addiction medicine. These are areas of the brain that can get overstimulated with things such as amphetamine use, methamphetamine, and not surprisingly, excessive methamphetamine use often will lead to a psychosis type presentation. We also want to think about the mesocortical tract. So meso meaning middle, the midbrain level. It rises and winds through the cortex, that wrinkly part of the brain. That's important for cognition, and so we don't want to impair this. Otherwise, we're going to create a cognitive impairment and dullness. And the nigrostriatal tract, which is involving things like uh, um, the sorry, um, the areas of the brain that are involved in smoothing movement, so such as the substantia nigra, that was the word I was looking for. Um, when we block dopamine there, we see these sort of Parkinsonian-like effects. And then finally, dopamine is involved through the tuberoinfundibular tract in the release of prolactin, which we want to generally avoid because excessive prolactin release not only will cause gynecomastia and galactorrhea, but can also cause demineralization of bones when we have chronic high levels of prolactin. So we're going for this sort of sweet spot of dopamine. When we have too much dopamine going on, we get into this sort of psychosis-like presentation. And that was what I was mentioning a moment ago when we overstimulate these dopaminergic tracts in the ventral tegmental area and in the nucleus accumbens, as we can do with things like methamphetamine, you can see this sort of psychosis-like presentation. But if we have underactive dopamine, we then get into this sort of dullness, difficulty with concentration. If dopamine is impaired in movement areas of the brain, the nigrostriatal tracts will have bradykinesia and sort of the symptoms that go along with Parkinson's disease. So we think that what's happening in the positive symptoms of psychosis is that we've got too much activity in this mesolimbic dopamine pathway. So the ventral tegmental area, the nucleus accumbens, that there's excessive dopamine activity happening there, and that accounts for things like hearing voices or having delusions or paranoia. But that there's insufficient dopamine activity in the mesocortical tract, and this is the area that we need to be able to think clearly and to have volition and drive and ideas. That this area of the brain may be underactive, and we see this as negative symptoms in patients with schizophrenia. And that everyone needs dopamine in the nigrostriatal tract in order to smooth movement and regulate movement. And that tuberoinfundibular tract, that's what regulates lactation. Just a refresher on dopamine receptors. So we've got two families. There's the D1 family, which comprises of D1 and D5, and then the D2 family, which is D2, D3, and D4. And generally, we are targeting with it, we want to target with our antipsychotics the D2 receptor. Some of the older antipsychotics tended to kind of cover all of these receptors, which is why they were less specific in their treatment and tended to engender side effects that come along with blocking dopamine across the board. Um, okay. However, when we get into the second generation of antipsychotics, then we start thinking about serotonin. And just a reminder on the serotonin receptors, there are these 7 different groups, 14 different serotonin receptors altogether. And the one that's mostly relevant for atypical antipsychotics is going to be that serotonin 2A receptor, which we are going to block. And that is actually going to cause dopamine release in the areas of the brain where we want to have increased dopamine, while not allowing dopamine to increase in the areas where we don't. Serotonin 2C blockade is probably what accounts for some of the weight gain issues that happen with the second generation antipsychotics. And that's just a refresher of what some of these other receptors do, which is less relevant for our conversation today. Just a reminder of some concepts from pharmacokinetics that are important here. One of the things that we'll talk about soon is the potency of these drugs. And the potency has a lot to do with the ability of the drug to stick to its receptor. Obviously, if a drug can't stick to its receptor, it can't do anything. So if a drug doesn't stick to the receptor, it's not active on that receptor. And we measure this in Ki, or sometimes referred to as affinity. And remember, the numbers are flipped here. So the smaller the number, the stickier the drug is on that receptor. And then we have activity, intrinsic activity of the drug. What does it do when it gets to the drug, to the receptor? Does the drug block the receptor? Does it activate the receptor? Does it turn the receptor off? And just a reminder that affinity is that Ki. So if we think about a drug like haloperidol, very sticky on the D2 receptor, it's like this guy in the lazy boy. He's not going anywhere. He's locked into that receptor, which is the chair, and he's not leaving. So we think about this as being really sticky on that receptor. Something like quetiapine, which has a much higher Ki and therefore is less sticky on the receptor, is more like this bus stop. You've got that little bench that you can sit down for a couple minutes while you're waiting for the bus, but then you're just going to get up and go on your way. So that's sort of like what quetiapine does on the D2 receptor when it goes by, it sits for a few minutes, and then it moves on its way. So it has a high Ki, meaning that it's not very sticky. And also, we need to think about what does the drug do once it attaches to the receptor. Many of the drugs that we're going to be talking about today are antagonists of the receptor. So they are sitting and they are blocking that receptor from being activated by something like dopamine or serotonin. So they are antagonists. They are blocking the ability of that receptor to be activated by its by its endogenous ligand, which would be the neurotransmitter. Now, we can also activate drugs. We can turn them partially on, activate receptors, with the drug. We can turn partially on with a partial agonist, or we can turn them all the way on with a full agonist. Or we can do the opposite. We can turn them partially off with a partial antagonist, or we can turn them all the way off with an inverse agonist. So when we talk about how different drugs work on the receptors, we're going to need to remember what they're doing once they attach to the receptor. For the most part, for the purposes of this conversation, we're going to be talking about antagonists and inverse agonists. Remember, the other way of thinking about this is thinking about this sort of speedometer here, so that remember these receptors all have a normal kind of firing rate, activity rate, and we are changing it relative to that intrinsic firing rate. So if we turn it all the way up, that's a full agonist. If we turn it part of the way up, that's a partial agonist. If we turn it part way down by blocking the receptor, it's going to be an antagonist, sorry. So it's still firing, but it's not firing at the same, it's firing at a slower rate than it would fire if the neurotransmitter was able to attach to the receptor. And then finally, we can have that inverse agonist where we turn off that receptor entirely. It's no longer firing. And these kind of charts, as complicated as they look at first glance, they're actually useful for kind of decoding what the drug does and also for understanding side effects. So as I mentioned, we can take a look at haloperidol at the D2 receptor, and we see that it has a fairly low Ki, 1.4. So we can reasonably say this is going to attach to the D2 receptor, and since we know it's an antagonist, it's going to block the ability of dopamine to attach to that receptor. But then we look at quetiapine. Its Ki is 310, so much less sticky on that receptor. It has much less occupancy of those receptors. And then we can take a look at the side effect profiles. So this is acetylcholine, ACH, muscarinic, that's what the M stands for, receptor. And here we see that the Ki for haloperidol is almost 5,000, which means it basically doesn't even attach here. So it really doesn't have anticholinergic effects. Whereas a drug like clozapine, its Ki is 34 on the muscarinic acetylcholine receptor. So from this, we can tell that it's reasonably sticky on this receptor. It's going to activate those receptors, and that's going to account for some of those anticholinergic side effects that we see with clozaril. When we think about a drug with regards to weight gain, we might think of something like quetiapine, which has a relatively low Ki for the H1 receptor, so 19 compared to this bloanacerin is a drug that's not it's not available in the US, but if it were, you could look at this and say, oh, 765 on the histamine receptor. This is probably a drug that's not going to make you that sleepy or necessarily cause weight gain, whereas something like quetiapine most certainly can do both of those things. So this is how we can begin to predict what kind of effects and unwanted effects the drug might have depending on where it goes on the receptor profile. Sometimes you also see this information laid out like this. So on the previous chart, we had a quantified number. This is more qualitative. So these are kind of relative to each other. Obviously, the more pluses there are, the more activity there is on that receptor. So for example, olanzapine, which is quite antihistaminic, is a 3+ here. You can sort of take a look at this on your own. Okay, so let's go ahead and stop this module there, and we'll go on to the next one where we start talking about the individual drugs going forward. Thanks.